Good evening, everyone, and welcome back to the Lipid Panel. My name is Dr. Guy Mintz, and I am the chair of programming for the Lipid Panel and working closely with Chloe Mativi from the National Lipid Association. The Lipid Panel was conceived as a lipid conference on a national scale. For those of us that have lipid clinics in our institutions, this is an opportunity for us to work with our colleagues from across the country to review diagnostic approaches, interface with different clinical findings, generate therapeutic strategies, and come together with colleagues. This is also an opportunity for us to explore different topics. So I'd ask everybody joining us this evening if there are any specific topics we'd like to explore. You can either email Chloe Mativi or even put it in the chat this evening so we can see what areas of interest are of importance to everyone. So tonight we have a presentation called Imaging Inside the Plaque, and we have a very uh, expert faculty for us this evening. Dr. Seth Martin is going to be our moderator. Seth is a core faculty member at the Cicerone Center for the Prevention of Cardiovascular Disease, where he directs the Advanced Lipid Disorders Program and co-directs Digital Health Innovations Laboratory. In addition, Dr. Martin serves as director of the Johns Hopkins Center for Mobile Technologies to Achieve Equity in Cardiovascular Health. He also serves as the chair of the AHA National Statistics Committee and is president of the Maryland American Heart Association Board. He's published more than 300 articles in leading medical journals and serves as editor on a variety of other journals. Our case presenter this evening is Kyvan Irannejad, who is an advanced cardiovascular imaging fellow at the Lundquist Institute at Harbor UCLA Medical Center, where he worked under the mentorship of Dr. Matthew Budoff. Dr. Matthew Budoff is a globally recognized expert in preventive cardiology, cardiac imaging, and atherosclerosis with over 30 years experience in academic medicine and clinical research. He is professor of medicine at the David Geffen School of Medicine at UCLA and holds the endowed chair of preventive cardiology at Harbor UCLA Medical Center, where he also directs the cardiac CT program. Dr. Budoff has led numerous NIH-funded studies. He served as a president of Society of Cardiovascular Computer Tomography and is a key contributor to the national and international guidelines of cardiovascular imaging and prevention. Dr. Edward Gill is a professor of medicine in the Division of Cardiology at the University of Colorado. At the Anschutz campus, Dr. Gill directs the Interventional Echocardiography Program and is co-director of the Hypertrophic Cardiomyopathy Clinic and is active in a leadership role in the lipid clinic as well. So with that, let me turn the program over to Dr. Seth Martin, who's going to be our moderator this evening. Thank you all for joining us tonight.
Thank you, Guy. Thanks to you and Chloe and the whole NLA team for making this possible. It's great to come together for this camaraderie and interesting discussion. So looking forward to the evening. Thanks to everybody who's joining. So we have a really interesting topic here with plaque imaging, and I think this is a hot topic in general, and especially in the context of the recently released dyslipidemia guideline, I think will be a particularly interesting topic. We certainly want audience engagement, so chime in with your comments and questions. But to kick things off, we're fortunate to have Kyvan here join us from the West Coast. Kyvan, without further ado, why don't you kick us off with your case and your slides? So over to you.
Of course. Sure. Good afternoon, everyone. I'm Kyvan. Today, I will be presenting a case that explores how advanced coronary imaging can help us better understand plaque biology and its impact on coronary physiology. So I'll start with the patient profile. Our patient was a 52-year-old Asian male with high cardiovascular risk. He had type 2 diabetes with A1C of 7.8, hyperlipidemia, prior smoking history, and a strong family history of premature CAD. There was no history of hypertension. At baseline, his BMI was 28.5, and his lipid panel total cholesterol was 260, LDL of 180, HDL of 38, triglycerides of 220, CRP of 5.4, and LPA of 72, which was normal. And he was not on any lipid-lowering therapy at baseline as there was no established primary care. His clinical status, he was asymptomatic, no angina or exertional symptoms. He was referred for coronary CT angiography for further risk stratification by his cardiologist. So he was referred to our Center for Coronary CTA.
Great. So we will move along. So this patient was sent to you that the cardiologist and the patient decided they needed plaque imaging for further guidance. It was
Yes.
quite Matt, before you get into this, I guess I wonder, Matt, if you want to just chime in on the case. Is this a pretty typical case that gets sent to you? Obviously there's a lot of risk here just from what we see on this screen, and patient clearly warrants lipid lowering therapy, but curious how this kind of fits in your world in terms of patients being referred to you for plaque imaging.
Yeah, we have a lot of patients who are reluctant to take statins or to go on medical therapy based on what they read, and Dr. Google often advises them against medical therapy. So I think a lot of doctors struggle with that. And for those patients who obviously, if he was just diabetes, multiple risk factors, very, very high risk individual, should be on a statin regardless. But I think we get a lot of patients who are either concerned or they just want proof that they need to be on a statin at this point in their life, knowing that it's probably going to be a lifelong therapy. So we do get a fair number of these. We use more calcium scoring in asymptomatic patients, so this is a little bit of an unusual referral for us because he clearly warrants treatment by almost any clinical criteria.
Great. Thanks, Matt. That's really helpful context. So yeah, despite the clear risk factor profile, the patient is kind of seen as believing the patient really needed to know what's going on with the plaque to have more certainty. And in the latest dyslipidemia guideline, coronary calcium has a very prominent role at helping resolve that uncertainty and grading plaque to guide decisions. But in this case, at the request of the patient and the cardiologist, the CTA was done. So Kyvan, why don't you walk us through what you found?
Yeah, of course. So the patient underwent CT angiography in March 2021. That was the initial evaluation when the patient was referred to us. And I put the slide. This is the axial image of the CT angio that was done. Initially, it showed obstructive CAD involving mid-LAD. You can see the yellow arrow pointing to the mid-LAD, the region of interest that I'm talking about, more than 70% stenosis. And the plaque morphology was predominantly non-calcified, as you can see in this area of stenosis. You can see the small amount of contrast in the mid-LAD surrounded by non-calcified plaques. So in this case, we sent the patient for CT-FFR to see the physiology and to see if the stenosis is functionally significant for ischemia. And I'm gonna talk about FFR in my next few slides, but just to talk about this slide, it was the mid-LAD CT-FFR was 0.55, indicating a functionally significant ischemia with the reference range of less than 0.8 that I'll show you later. And based on this finding that the patient was FFR positive and it showed a high risk, it showed a high grade stenosis in mid-LAD, the patient was started in high intensity statin and along with guideline directed medical therapy for secondary prevention, including aggressive risk factor modification.
Great, thanks, Kyvan. Ed, why don't we bring you into the conversation? So now that you see this, we know that the patient was asymptomatic, but we're seeing this positive FFR. We're seeing there's a lot of non-calcified plaque. The patient, when it was in his early 50s. What do you think about this? Are these findings kind of what you expected? Are you surprised? What do you make of this?
Yeah, great question, Seth. I have to say, going back to the time when I was a cardiology fellow, I'm never surprised at the findings that we get on invasive or non-invasive coronary angiography, because the patient that you think certainly should have terrible coronary disease ends up having none. and the opposite is sometimes true. But clearly this patient is reasonably high risk, so finding significant coronary disease, even though he's relatively young, is not surprising. And of course, we're going to talk about the fact that this plaque has some particular characteristics that we'll want to talk about more in terms of whether it's a risky plaque or not risky plaque.
Okay, great. Thanks, Ed. And so the patient did get started on high intensity statin therapy. Given the high baseline LDL, it's possible the patient would need combination therapy, but that's certainly a good start. Let's keep going. Come on, back over to you.
Yes, so the patient was following up with the primary cardiologist, and after 4 years, he was sent back to us for surveillance CTA with CT-FFR in December 2025 to see if there was any plaque regression, stabilization of plaque, and to see how was the response to the treatment. So you can see the 2025 scan, the same slide that I showed, the axial image of mid-LAD. You can see marked regression of non-calcified plaque in mid-LAD and improvement in luminal caliber without progression of calcified plaque burden. And we also sent for FFR. FFR also showed mid-LAD CT-FFR improvement from 0.55, which is in the ischemic range, to the 0.77, representing a substantial improvement in coronary physiology and no longer in the ischemic range. So we can obviously see regression of non-calcified plaque in the CT angiography here compared to the last scan that I'll show in the next slide, with significant improvements in coronary physiology confirmed by CT-FFR.
Great. Thanks, Kyvan. Matt, any comments here? Were you surprised by this? Have you seen this type of improvement in other patients that get started on lipid-lowering therapy, risk factor modifying therapy?
I mean, this was quite a dramatic case. I think that's why Kyvan picked it. We really don't tend to see this type of regression, and unfortunately, many of these patients where that yellow arrow would have a stent there right now after a 70% stenosis and a positive FFR CT. I think a lot of people would have gone down the revascularization road. So I think this is a big win for preventive therapy. Fairly modest treatment, but a very nice response. Just showing you, sometimes we don't need to go to double, triple, or quadruple therapy to invoke some benefit for the patients. But this is clearly an outlier.
Great. Thanks, Matt. Kyvan, remind me, do you share the follow-up kind of lipid LDL level later?
Yes.
Okay.
Yes.
Okay.
Yeah.
Okay, back over to you.
Yeah, so in this slide, you can see on the left side, the 2021 scan. This is a curved view of LAD. And the left side, you see the baseline versus the follow-up after 4 years. On the right side, you can clearly see, I zoomed in this small box, you can see the mid-LAD region that going from high-grade stenosis to non-obstructive CAD, you can clearly see the contrast flow toward the distal part of the vessel and reduction in amount of non-calcified plaque in the follow-up scan. And this slide, this is the CT-FFR improvements in mid-LAD. So as you can see, just a very small introduction about that is the CT-derived fractional flow reserve, or CT-FFR, provides a non-invasive assessment of lesion-specific ischemia by showing the hemodynamic significance of coronary stenosis. So it shows us the physiology. As you can see on the left side, you see the FFR 0.55, and in the scale, you can see less than 0.75 is marked by red. And in this vessel is highlighted by red, which means that it's positive for ischemia and it's in the ischemic range. And on the right side, which is the newest scan, it showed it dropped to 0.77, which is significant improvements in the physiology confirmed by the CT-FFR.
Excellent.
Okay, so till now we spoke about CT angiography. We visualized the mid-LAD that we saw the regression of non-calcified plaque in the area of interest. We confirmed the physiology improvements by looking at the CT-FFR, and this is the third way of confirmation that there was plaque regression. We sent for plaque analysis by heart flow. So it's showing on the left side, you can show the LAD plaque volume, total plaque volume. It gives us the calcified and non-calcified percentage and the volume. You can see in the baseline scan, it was non-calcified of 85, calcified of 20, and total plaque volume of 105. And as you can see in the middle of the screen, you have the region of interest, which is 50 millimeter from ostium. And it showed, this is the newer scan, new FFR. It showed from 2025, showing 30% to 49% stenosis, which is non-obstructive CAD. And the plaque volume in 2025 went down from, the non-calcified plaque went down from 85 to 59, which is significant. And also total plaque is dropping from 105 to 99. So generally, we expect the calcium and the plaque volume to go up by like 10% each year. So in this case, it didn't go up, and it's also reduced from 105 to 99 in the LAD, and with significant reduction in amounts of non-calcified plaque.
Great. So yeah, the non-calcified plaque came down. There's a little bit of calcification of some plaque.
Yeah.
Quick question. Were these scans performed on the same scanner at your institution?
Yes, it was
Okay,
performed the
great.
same scan. Yeah.
Great. I wonder, maybe Ed, do you want to make any comment around the importance of, if there are comparisons between scans around using the same scanner?
Sure, Seth. So certainly to have a good handle on the certainty that you really can compare the plaque volume as well as the parameters that we're going to talk about in terms of whether the plaque is higher risk or lower risk based on calcified, non-calcified. It certainly is advantageous to have the same scanner, but not only the same scanner, but also the same software to analyze the plaque. And in fact, I would think that the plaque analysis package would be pretty critical to be the same one if you're going to compare all of those parameters, not just the calcified and non-calcified, but particularly the low attenuation and other characteristics as to that we're going to talk about in future slides that are markers for a plaque that is more likely to rupture, which is really what we're talking about here. And I agree with Matt that I was kind of surprised that we saw this much regression on the particular lipid lowering regimen that was used here, just 80 milligrams of atorvastatin. I'd have to say if I had to do this over again with no knowledge of what was going to happen going forward, I feel like I would have put the patient on at least two agents, given how I hate to use the word scary, but scary that mid-LAD plaque looked like initially. And I think it takes some patience and, actually some, patience on both the doctor and the patient themselves to sit back and go on these lipid lowering agents and see what's going to happen, as opposed to doing like next test is a stress test. It's abnormal, and the next thing the patient has a stent in, as Matt said.
Great, thanks, Ed. I see we have a couple questions in the Q&A, so maybe we'll pause and get to those. But real quick, Matt, did you have anything you wanted to add on importance of same scanner, same technique, same software? Anything to add there?
I think it's just so important, Seth, and it's great that you brought this up. I think the concept of if you're going to rescan somebody, especially if you're going to try to measure plaque volume, you have to do it with the same software for sure. You should definitely try to do it on the same scanner, and optimally, you would try to do it with the same settings. At least the voltage, the kilovolts should be similar. So if your patients are going to go back for a follow-up scan and you've been trying to follow them with plaque progression, like in this case, you should definitely ask the center to emulate the first scan and keep as many settings as possible similar. We do that in our clinical trials when we track drugs over time, but it's important clinically as well.
Great. And Matt, maybe I'll stick with you for a moment because we have a question that kind of builds on what you were already starting to speak about earlier around CAC versus coronary CTA. So the question, thank you, Jenny Sager, for the question, why straight for coronary CTA, not starting with CAC? Of course, the decision here was made by an independent cardiologist and their patient to refer. But, and of course, CAC is the more commonly used tool and has more prominence in our guideline. I wonder though if you want to, I think you started touching on this earlier, if you want to expand on sort of, using when to move to CCTA versus CAC.
Yeah, no, thanks, Seth. I think, I think CAC is always, for me, always the starting point. I think if the calcium score is very high and patients are concerned about stenosis or other questions that we can't answer, how much non-calcified plaque or low attenuation plaque is present, sometimes we do move up that algorithm, but I always advocate for asymptomatic patients to start with a calcium score, and for symptomatic patients largely to start with a CT angiogram. And I think that's a simple algorithm. Most of my referring doctors do that, but there is, and there has been a push by some of these vendors and some doctors of notoriety that are suggesting that CT angio provides so much more information. Why not just get that as your baseline study and go from there? And fortunately, this person didn't end up with a stent being an asymptomatic person, but I have seen that happen, which it's hard to happen from a calcium score because you don't know that stenosis is 70%. You just know they have a lot of plaque, and you start treating them aggressively, as Ed outlined. So I think CAC is safer for patients from a perspective of revascularization as well.
We have another question we'll get to in just a moment, but Jenny, thanks for the follow-up question about 50% of CAD being asymptomatic until the first event. So maybe why don't we go to you, Ed? We'll take Matt off the hook for a second. Ed, do you want to comment just on how you think about symptoms, before an event, and the statistic that Jenny's quoting around 50% of coronary disease being asymptomatic?
Yes, I think it's a scary statistic for sure. But I guess specifically, Seth, are you asking me if I tend to go directly to CT as opposed to calcium scoring or other modalities kind of thing, or where are you going?
Yeah, would love to get your quick thoughts on that. And then we have one other question I want to come back to Kyvan and Matt about. So would love to get your quick thoughts, Ed, on how you see CAC versus CTA and how symptoms play into your decision making.
Yeah, I mean, I would reiterate what Matt said. If a patient is symptomatic, I go directly to coronary CTA. And that's fitting with current guidelines as well. If they're asymptomatic, then certainly start with a CAC score. I am sometimes worried when I have only the CAC score and it's kind of in an intermediate range. If it's very high, like in the 80th or 90th percentile, I often move to coronary CTA, and that's moving along with what the new lipid guidelines are suggesting, that that coronary CTA is going to play a bigger role as we move on. And certainly, even before that, coronary CTA was moving towards having a bigger role in our day-to-day practice. And separate from that, whether we're ordering it or not, we're often getting patients like this that are having coronary CTAs ordered outside of our purview, and then we're asked what to do with that. And that can be sometimes challenging, especially in a patient like this where you have a stenosis that is pretty high grade and the FFR is positive and all of those things. But yeah, I mean, I have to say, every day that I practice, I'm having more and more patients have coronary CTA either ordered by myself. I try to use the most appropriate use of the test, or referred to me by other providers because the patients have had them. And certainly, as everyone knows, with Dr. Google and ChatGPT out there, there's enough patients out there that are using them, and they come to us wanting to have a coronary CTA, or coronary calcium score at the least.
Great. Thanks, Ed. Well, we have a couple questions we'll do run through quickly and then move on. I just want to reemphasize what's been brought up about our latest dyslipidemia guideline from ACCHA and with multi-society collaboration led by Dr. Roger Blumenthal and Dr. Pam Morris. CAC has class 1 recommendations in the guideline to guide dyslipidemia management. There is a 2B recommendation for coronary CTA quantification of plaque with particular call outs to individuals that would be more likely to have non-calcified plaque, such as individuals with HIV. Let's tackle the question around insurance. I wonder if Matt, Kyvan, can you quickly comment? The question is being asked if this patient actually had the insurance pay for this, or did they pay for it out of pocket?
I'd say there's no large insurance coverage yet for CT angiography in asymptomatic patients. It's excellently covered in symptomatic patients, but I think this is a largely cash out of pocket expense. So calcium scoring being 4 to 8 times less expensive, and I think quite informative. I always try to encourage people, if they want a first test, to start with a calcium score. And then, as Ed outlined, if there's surprising findings or significant findings on the calcium score, you can always go to the next test. And often at that point, it is covered because they have a diagnosis of athero from the calcium score.
Great. And we have a question around regression in the plaque by CTA. Is that linked to hard outcomes? Of course, we do have quite a bit of data now on the burden of plaque being linked to outcomes. Is there good data yet around a regression being linked
So
to outcomes?
there's great data on progression on CTA and subsequent outcomes. So Motoyama and Jack, in as early as 2015, started publishing. She's from Japan and published some wonderful cohorts showing us that if you have plaque progression between CTA scan 1 and scan 2, you're 33 times more likely to suffer an MI or die over the subsequent follow-up period. But I'm not familiar with data showing that if you have regression of plaque, that you have less events or are protected. But I think that would just be a natural extension of that type of work.
Great. Thanks, Matt. Okay, let's see if we can do some rapid fire answering some of the questions we have here, and then we're going to move on. We had a question from Madhvi Maddie Kadiyala, finding this to be a very nice illustration of plaque stabilization. Have had cases sent for second opinion after plaque analysis called non-calcified plaque volume in a patient reported as CAD-RAD 0. Is the software overcalling the plaque, or is the reader missing a subvisual threshold? Given the lack of outcomes at this stage, what's the recommendation? This is, I think, a question that keeps coming up around overcalling. Curious, maybe Matt and Ed, would love if you could just each give me your brief thoughts on that.
Yeah, I look at a lot of studies, and I've been looking at coronary CT angio since 1995. And I got to tell you, I think when I see normal coronaries, I'm pretty confident that there's not much or nothing there. But some of these AI software are finding some minimal plaque. I would consider it like trivial plaque. I wish they would rename it from mild to trivial, like we do maybe with MR or AR, where you see a trivial regurgitation, you don't make a big deal about it. But I do see they are, I think, overcalling at the low end.
Great, thanks. Do you agree with that, Ed?
Yes, that's been my experience as well. Don't have nearly the years that Matt has looking at these scans, but I think of the cases that I've been talking about, of more and more of these patients coming to me, I'm not seeing very many, if any, that are called normal. Almost everyone has some degree of plaque, and that does make it problematic in terms of what you're actually going to do with that. I mean, obviously they're going to be on lipid lowering therapy, but the question is, how low should you go? How intense should you make the therapy? And should you add other agents, which is going to be the subject as we move on here.
Great. I see we do have a couple more questions, which I do really appreciate, and please keep them coming in. I think what we'll do is save those for a little bit later. Kyvan, I'm going to pass it back to you so you can get through your section here, and then we'll continue the discussion later.
Yeah.
All right, let me advance that for you.
Yeah, so in this slide, I just summarized the LAD plaque metrics that compares the old scan with the newer scan. It shows the total volume from 105 went down to 99, non-calcified from 85 to 59, and calcified from 20 to 40, which means a stabilization of the plaque, and it's expected. But the other thing is the LDL, which reduced dramatically from 180 to 60, just on high intensity statin, atorvastatin of 80 milligram. After 4 years of therapy, we see from 180 to 60 with concurrent improvements in plaque burden and composition.
Okay, maybe I know folks had comments around mono versus combo therapy. Maybe we'll circle back to that, but why don't you take us through the rest of your discussion and takeaway points?
Yeah, sure. So our discussion, this case demonstrated like the targeted regression of non-calcified coronary plaque accompanied by improvements in coronary physiology that was evidenced by CT-FFR over 4 years of intensive medical therapy. So our teaching points here would be non-calcified plaque is dynamic and modifiable, particularly with aggressive lipid-lowering therapy. Intensive lipid-lowering promotes plaque stabilization characterized by a reduction in lipid-rich plaque and increased calcification, as we saw in this case. CT-FFR enables non-invasive assessment of lesion-specific ischemia and its longitudinal improvement, so we can always do a serial CCTA plus CT-FFR as a powerful tool for monitoring therapeutic response, even in asymptomatic high-risk patient, as we saw in this case. And imaging-guided risk stratification may support optimization of medical therapy and defer invasive intervention. And my last take-home messages would be aggressive lipid-lowering therapy can modify plaque biology, leading to regression and stabilization with meaningful improvements in coronary physiology, and CCTA combined with FFRCT enables non-invasive tracking of these changes and supports personalized cardiovascular care. And I finish my presentation with this sentence that is my conceptual takeaway from this case, that treat the plaque and the physiology follows.
Great, thanks, Kyvan. We're going to now move on to Ed, who's going to guide us through some teaching points and has some audience response questions. I think that let me just see how we're in terms of additional questions that are coming in. I know we had two there. Okay, they're still there. Okay, let's tackle one of those and then we'll move on to you, Ed. So thank you for the question. It's interesting that the physiology and degree of stenosis of the lesion improved dramatically while the plaque volume and composition did not change significantly. Expected that soft plaque became calcified. Any thoughts on the mechanism for this role of shear stress? Kyvan, what do you think about that?
Yes, I think we saw the regression in the non-calcified plaque. So it was a significant regression in non-calcified plaque. It was expected, like the calcium score expectedly went up, which means a stabilization of the plaque. But also the important thing is that the degree of stenosis from 70%, which is in the ischemic range, went down to non-obstructive CAD, which is like in the 30 to 50% range. So we had like the physiology improvements, and we had some some non-calcified plaque for sure to be calcified and be stabilized. And also we saw in the like the curved view and in the axial view of the CCTA, the regression of non-calcified plaque. So I think it was significant, the physiology, the stabilization of the plaque, and the regression of non-calcified plaque itself.
Great, thanks, Kyvan. And as Matt pointed out earlier, it really did take quite a lot of restraint, to not, intervene on this lesion, which then with a stent, which was appropriate in the setting of the patient being asymptomatic, but ultimately allowed to see the response to medical therapy. Let's Ed, let's go to you, and maybe if you could go through your teaching points, and it'll be interesting to see how the polls go over maybe the next 10 minutes or a little bit more, and then we'll make sure we have time to address all the great questions that are coming in at the end. So Ed, over to you.
Great. Thanks, Seth. I will just make a quick comment about the question about does regression result in reduced adverse events? And Matt, I'm not trying to scoop you or anything here, but I did use some resources here and come up with an article from JAMA Cardiology from 2023, which I'll put in the chat later. It's a meta regression analysis showing that for every 1% decrease in percent atheroma volume showed a 19% reduction in the odds of MACE. So
Is that using IVUS or CCTA?
um, that was, haven't read the article, Seth, so it looks like a combination of therapies or imaging. I'll get back to you on the details on that. That's a great question.
Okay.
But looks like it's predominantly CCTA. So getting back to the teaching slide here. So initially the idea was to show what the major CT characteristics for high-risk plaques are and going from left to right and from top to bottom. So the low attenuation plaque is kind of the workhorse, if you will, that we look for looking for signs of a plaque that is more risky. And there's actually a cutoff that if your low attenuation plaque is more than 4%, that your risk of having an event goes substantially up. So that's defined based on Hounsfield units, as shown there. And then positive remodeling, that's defined as when the outer vessel diameter gets larger, and then the plaque to average outer diameter shown there is greater than 1.1. Spotty calcifications are shown as areas surrounding the coronary artery that show little tiny areas of, as shown there, punctate calcium deposits. And then finally, the sign there, the napkin ring sign. So that's essentially an area of low attenuation plaque surrounded by a ring-like area that's peripheral hyperattenuation rim. So essentially, as the sign suggests, the name, the napkin ring, so essentially having a ring around your low attenuation plaque. Next, management perspectives. So we all know that lipid lowering is the first mainstay. And then the type of lipid lowering, statins are what we all reach for initially. These days, almost all of our patients are on statins, right? I think that one of the take-home messages from this talk might be that to have a low threshold for going beyond that, and particularly have a low threshold for using the PCSK9 inhibitors, because I really think that we should be aiming for lower than we have been. The new lipid guidelines say less than 55. I would argue even lower than that, but we can have our own internal argument about that. And then you can see there's a big arrow there saying that there's evidence gap. So the question is there going to be a patient that we want to do a preventative stent, which might have been brought up in the patient that Kyvan presented here in other institution. And again, it's important to have enough patience and enough perseverance to not go to that step if it's not needed. I won't talk a lot about future perspectives at all, but one of the main limitations that we face right now is people that have a lot of calcium and looking at their coronary arteries with coronary CT, that's a real limitation. And the new technology of photon counting is a way of getting over that. Coming or novel imaging and serum markers, and then artificial intelligence obviously is already playing a huge role in terms of analyzing plaques, and then radiomics. And so mixing markers with radiology to identify plaques that are particularly high risk. Okay, next slide. So yeah, good time for our first audience response question here.
What are the stages of severity of plaque as classified by coronary CTA? We'll keep this open for a few moments. I don't know if we could get any special music, but Chloe, I think that's good enough time. We could go ahead and close it out. Thank you. All right, so the answers are really across the board. So this will be great, Ed. Why don't you teach us more about this? Okay.
Sure. So we have a slide coming up in a
Yep.
couple that will actually document that, but it is shown and the answer is grade 0 through 3, but we'll see that in a slide or two here. This is just a illustration from publication about both coronary CTA as well as plaque biology, going all the way from on the left to no coronary disease to on the right, actually showing stenosis. And as we've grown to know all too well, is that the plaques that are most likely to rupture are frequently and actually predominantly plaques that are of low-grade stenosis, those that are less than 50%. And those are the ones that we need to identify in the way that we're identified. So if you look for the second area there, were early inflamed coronary plaques. So this is a new way of looking at essentially the basal vasorum of the coronary artery and showing that perivascular fat attenuation index is a way of showing the degree of inflammation of the basal vasorum. And then moving on one step further, the non-calcified plaque, and Kyvan has already talked to us about low attenuation plaque, and then more about assessment of coronary disease all the way to fractional flow reserve. And we've talked already about fractional flow reserve and what's significant there. And as we go all the way from left to right on our upper coronary artery there, we go from, as you can see, the plaque that is soft and made up of mainly smooth muscle cells, macrophages, and infiltration of neutrophils and such, to all the way to the end when it's calcified. And we want it to become more calcified because that is a marker of more stability. Okay, next slide, Seth.
All right, we have another audience response question. What are the two markers of high-risk plaque beyond the obvious ones that are listed here?
Seth, I think the moderator is supposed to hum the Jeopardy tune.
Yeah, very good.
Do 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 do. All right, I think that's a good enough time to see where we're at. You don't want to hear my singing too long. High fat attenuation index was the majority answer, Ed.
But the audience is clearly very attuned here, Seth.
Mhm.
So, yeah, high fat attenuation index, that's perhaps the hottest index on the block right now. Have Matt comment on that as whether he agrees or not. But they also got the second one right, which is intraplaque contrast enhancement. Short longitudinal plaque length is not a marker of high risk, and then a calcium score of 100. Well, the higher your calcium score, the more worried we are about you having plaque per se, but then the higher, the more calcified your plaques are, in theory, the more stable they are.
Yeah,
Great.
I would just say real quick, I think fat attenuation index, just working on more validation, but the early data is impressive with two large cohort studies. So Orphan and CT Crisp. So we're definitely interested, if not validated yet.
Okay. Okay, great. So let's see. We just a time check. We have 15 minutes left. Matt and Ed, let me know at what point you think it makes sense to flip ahead as well to your colchicine slide at the end, Matt. Do we want to do that now or in a little bit?
I'm open to either, whatever Matt
Yeah,
would like to do.
I'm good. I'm whatever you think will
Okay.
be best, Seth, for flow.
Okay. All right. Do you want to? It seems like you could go through this pretty efficiently, Ed. The audience was pretty in tune with here.
Agree. Let's just skip through this slide, Seth. It doesn't really have any new information. This is only a diagram of going through the four things that we've already talked about, but it also has a CT scan to go with the illustration, which I think is nice. So the positive remodeling, you see the artery enlarging, the low attenuation plaque. Our patient example had that. The spotty calcification, so you see those little punctate areas of calcium that are shown by the red arrow. And then finally the napkins ring sun, which I have to say is probably not illustrated as well as we would like on the CT. But for more information, many of my slides, as you see, have a QR code that you can use to actually go to the article and do some deeper reading. Okay, let's move on. And then this is actually a very interesting case report of they actually took a patient who had coronary disease, explanted their heart, and injected their coronary with dye and then did a CT on it. So next slide. And you can see the white arrow shows where they injected, and the two black arrows, if you will, the arrowheads show areas of punctate spotty calcification, and then each of the cross section shows where they actually showed the CT, and they have a pathologic slide as well. So next slide illustrates all that. So you see the red ring and arrowheads shown on the inset in A and B show the areas of higher attenuation plaque, and then the starred area again on the inset shows the necrotic core plaque, lower attenuation, and you see that in slide C, the actual pathologic slide. And then again, for more in-depth reading, you can click on that QR code and look more into it. All right, next slide, Seth.
Okay, great. Brings us to our next audience response question. What anticoagulation regimen has the most evidence base for treating grade 3 severe non-obstructive coronary plaque formation? Is it warfarin, rivaroxaban, aspirin, Plavix, or is it B and C? All right, we'll try this again. Do. Unless somebody else wants to take over.
It's definitely not me, Seth.
Do.
Let's have the audience.
Okay. All right, let's see what we have here. So let's see, B and C was a popular choice, 37%, but so were some of the kind of the single answers. Ed, what do you think?
I think this is great with regard to providing a platform for discussion. And so when we think about the real pathophysiology and the biology of the plaque and what we need to do to prevent a thrombus from actively forming, clearly we want some sort of anticoagulation, and we want to have the most effective anticoagulation. We think of trials like the Charisma trial, for instance, which showed the combination of aspirin and Plavix was superior to aspirin alone in patients with sort of active coronary disease. But what we're often talking about here in our patients that are getting coronary CTAs, maybe not so active, but more chronic atherosclerosis. And so the Compass trial was a trial that compared rivaroxaban plus aspirin to aspirin alone. It's actually published almost a decade ago in 2017, that showed superiority to rivaroxaban plus aspirin, and again 81 of aspirin. So not sure that it exactly goes with our patient here, for instance, but you'll see a slide coming up here where I actually show grades 0 through 3 plaque and what would be the treatment for it. So the correct answer is B plus C here. And voila. So here is a slide that was originally provided to me by Matt, but from Freeman. You see this is from the American Journal of Medicine 2022. And we're looking at the stage of plaques here going from 0 to 3, as we've already discussed, and what you might use in terms of your treatment. And this is recommendation. I guess first time I saw this, I was a bit taken aback with regard to stage 3, which are clearly severe plaque, but yet, less than 50% stenosis. But you can see, 0, mostly lifestyle, grade 1 statin and ezetimibe. And our patient was probably beyond that, was more like in the stage 2 range. And that was in part why I said I would have used at least a statin and ezetimibe here. But if you go all the way to stage 3, note that consider PCSK9, icosapent ethyl. Matt could comment on his study, the evaporate study that showed regression or at least halting of atherosclerosis with icosapent ethyl. And then the other agents, including bempedoic acid, colchicine, which we're going to talk about, and GLP-1 and SGLT2 if diabetic. But particularly to emphasize, once you get to stage 2, as shown here, adding aspirin and rivaroxaban, and then when you're stage 3, keep in mind that we're recommending everything above. So essentially from stage 2 on, we're recommending aspirin and rivaroxaban. Sorry, I was a bit wordy there, Seth.
Thanks for walking us through that, Ed. I think what we're going to do in the interest of time with about 10 minutes left is we're going to dive into the inflammation piece for a moment. Matt, I'm going to skip ahead to your slide. Let me get us to that. And as we recall, this patient did have a CRP level of 5.4 milligrams per liter. Matt would invite you to walk us through this piece around colchicine. Then I want to make sure we leave a bit of time here to dive through some of the questions that we have.
Certainly, yeah, I'll go quickly. I think, there's been a number of positive outcome studies with colchicine and stable CAD. I know that the recent Clear Synergy trial cast some doubt on acute MI, but I think there's some excellent data, and it is indicated actually for treatment of coronary artery disease to reduce cardiovascular events. So I think this study was just a proof of concept trial. 0.5 milligrams of colchicine once a day did reduce plaque volume. You can see it slowed plaque atheroma volume. When we looked at total plaque, and percent atheroma volume was much lower with colchicine on top of background therapy as compared to placebo. And on the right, you can just see a nice example of that patient with some regression. So I do think that we do, we're still looking for more data, but I do think that colchicine low dose is safe. I do use it in time to time once I've addressed the lipids adequately, and I'm comfortable with the lipids. If they're still progressing, I think about this as another potential mechanism of benefit.
Thanks, Matt. Very provocative data, and in this particular patient case, I guess as far as we know, it wasn't started. Is it something you would have been thinking about pulling the trigger on for this guy?
I think so. I mean, obviously, I would have started with his dramatic LDL abnormalities, then his hemoglobin A1C, and make sure that's under control. And then if he's still progressing, or if he's still having, concerns, I think that would have been, with that high CRP, I think this would have been the third line of treatment down the road.
Okay, great. All right, thanks, Matt. Well, I appreciate everyone who's been staying with us here towards the end, and the questions that have come in. Some, I think, are very rapid ones. Thank you to J.R. Nelson, who said that study was with IVIS. So we appreciate you chiming in there. There's a question about the slides being available to download. So maybe I could ask Chloe and Guy, the NLA, to maybe put a chat message about slide availability. So let's get into the first question we had. Thank you, Patrick Key, for your patience. I know you put this question in a while ago. And this brings up another interesting case. So you have a 62-year-old man with elevated LPA, strong family history of premature disease, CAC 550, greater than 80th percentile. Left main has a majority of the CAC score at 375. Patient's asymptomatic. Cardiac PET shows no major perfusion defects. He's asymptomatic, as you said. Should I trust his PET results and treat him medically, or should I perform a coronary CTA to look at his left main? And will this level of calcium affect the accuracy? Matt, you want to chime in?
Yeah, I would just say PET has excellent sensitivity and specificity, and I would trust a negative study. If not, it shouldn't have been ordered in the first place. You have to rely on the tests you get. But I think PET is excellent. If you said nuclear MIBI or stress echo, I would think about a CT angio as the next step.
Great, thank you. And that is consistent with the asymptomatic status of the patient. Okay, let's see if we can get. I'll just go in the order here. We'll see how far we can get. Jenny, you get the prize tonight for the the most questions here. We'll have to send that to you in the mail or something. So between initial CTA and follow-up, aside from statin therapy, were there other interventions? Feel we cannot underestimate the power of nutrition, other lifestyle factors. I guess I'll chime in for the group. I'm not sure that it's known what other interventions how much counseling around nutrition, all that was done. Certainly that is the foundation of prevention, and we would wholeheartedly agree with you that that should be reinforced along with statin therapy, as well as, blood pressure control, diabetes control, the whole comprehensive approach. Matt, anything else? Kyvan, anything else to add that you knew about the interventions behind the scenes?
No, it was, yeah.
But I think you're right, Seth. We have to always remember diet, exercise, lifestyle interventions as first line, as in addition to other therapies.
Okay, great. Okay, let's go back to Veerpan, who has questions around the changing plaque composition can reduce outcomes, but does it change physiology and/or luminal stenosis? So it sounds like they can understand how the intervention, the statin, changed plaque composition, but does it change physiology, luminal stenosis? How do you kind of connect the dots with those other endpoints?
I think dramatic LDL reduction can definitely regress plaque. The original studies were actually done in quantitative coronary angiography showing stenosis regression. So I think as we get LDLs below 55 milligrams per deciliter, we've seen fairly universal regression. It's not liquid Drano. It's not going to happen quickly, but there can be some regression of stenosis as well as improvement of physiology. We even showed with icosapent in the Evaporate trial that FFRCT improved. So physiology can definitely improve with plaque changes, as Kyvan showed us.
Mm-hmm. Great.
And I would add to that, Matt, is like with regard to this specific question about changing the physiology. I really think that's where anti-inflammatories come into play, particularly colchicine. They can actually have a direct effect on macrophage and, leukocyte infiltration. But reducing LDL has that effect too, because LDL is a very inflammatory molecule as well. LPA was normal in our patient here, but I do want to point out to the audience that LPA has been shown to be 6 times as toxic as LDL, and a major cause of infiltration of macrophages due to it being a harbinger of oxidized phospholipids. And whenever LPA is hanging out, it's releasing those oxidized phospholipids, which are very toxic.
Great. Thanks, Ed. I recognize we're up on time. We have just a little over a minute left. I want to acknowledge in the chat, thank you, Ed, for sharing the JAMA Cardiology paper, and you did confirm JR's comment that it was IVIS. The NLA, Chloe, thank you for chiming in that the slides will be posted alongside the recording, and you gave the link. We're up at the end. I think, Kyvan, you kicked us off with a great case. Thank you so much for getting us going with that. It is very helpful. I think drove a great discussion. I'm going to give you the final word, Kyvan. Anything you want to add to what's been discussed, or additional takeaway messages for the audience?
No, it was like a great opportunity to present this interesting case. I think it covered all aspects of the case, treatment-wise, diagnosis, and like the high-risk plaque features. So I think, yeah, I have no other points to add.
Well, I wanted to jump in here. I want to thank the panel. Excuse me, outstanding case and outstanding discussion. We could have certainly gone on for more time. I want to invite everyone to join us next month, April 28th. The last Tuesday of the month is always the lipid panel. We'll be having some interesting cases around lipodystrophy, so please join us. And again, thank you to Matt, to Ed, to Kyvan and Seth. Great stuff. And everyone have a great evening, great holidays. Thank you.
Thank you.
Take care, everyone.